Is going to be, I'm sure it is going to be very interesting program, because for this I think I have spent a lot of time, a lot, to prepare it. And I tried to keep it in a way that we can really give justice to the pluses and minuses of both the technologies and how should it be used, depending on the case. Keith, can you announce the panelist and we can start? Yeah.
On the panel we have Dr. Akasaka, Dr. Abhiram Prasad, Dr. Samir Pancholy, Dr. Tejas Patel, Dr. Ramesh Vijayvergiya and Dr. Ajay Mahajan.
Rajesh Vijayvergiya and Ajay Mahajan are outside. You can call them. And Professor Akasaka also. And we can just get going. So maybe within 2 minutes we can start. The cases, I tried to keep them, I thought that they are relatively simple cases as compared to regular TRICOs, but I think it was other way around. But anyways, the things went on well and there was a good discussion. Ajay, please. So yes, Professor. Rajesh Vijayvergiya is also on the panel, and yeah, let us start. So I am going to throw sometimes the history part, sometimes the imaging part. Rajesh, please. And then we will build up the discussion. Anytime you can interrupt me or you can interrupt any of the panelists and ask the questions. So this is case 1 and this is a OCT image. Now looking at this OCT image, what comes to your mind? TCFA, right. So how many of you think it is TCFA? I think you know it, so you don't speak. You can see through it. So yeah, anybody who is new or even not doing regularly or even doing regularly but not giving proper attention to the detail would get stuck with the finding TCFA, right? So this is the history. Patient presented, why TCFA? Because it's a thin cap and then it looks like all fat area involving 2 quadrants and then lot of fibrosis. This is the history. Acute inferior wall MI, diabetes, COPD, 69-year-old man, a post-MI angina, presented with moderate LV dysfunction. So this is, many of the data are on the basis of an investigator-initiated protocol which we are doing, IOPUS, where we simultaneously assess IVUS and OCT for particular segment or particular lesion. So this is the picture. Right is totally occluded acute MI. So right, it looks like, yeah, somewhere the plaque must have ruptured. This is the IVUS picture of the same area. What is this?
Large hematoma.
Hematoma, yeah. And now you see both the images together, the same spot. So sometimes, because the IVUS cannot visualize very distal area, it can misinterpret hematoma as TCF. And now I want your opinion, Professor.
Yes, in this case, the beam of the OCT is parallel to the distal portion, right, of the hematoma. At that time, it might be very difficult to identify this is TICFA or not. If the beam is perpendicular to the...
Yes. Yes,
hematoma.
because it is bulging like this,
Yeah.
you think that there is a hematoma behind, right? If it is straight, you think of TCFA. That is what you want, you mean, right? Yeah.
But a plaque burden just beneath this thin cap is very much suggestive that possibly we are dealing with the thin cap fibroathyroma over here.
Yeah.
But a run over here could have given some idea about what's going on.
Yeah. Yeah,
A
but-
OCT run at this particular place and
see-
proximally and distally a dissection flap can very well give some idea, some clue about, say, subintimal hematoma which is present at this
Precisely, Rajesh, that is the reason why we are in the habit of, even interpreting and reading, the image portion very hurriedly, and this is the case, and you can make the mistake. Ultimately, this was the result. This is another case. Now here I am throwing an angio image. What do you appreciate here in the angio? No, but in angio, can you see the calcium,
There is severe
fluoroscopic calcium?
calcification.
Huh?
There is significant calcification, circumferential.
Yes. Circumferential calcium, both walls are calcified, right? Yes. Now, balloon dilatation done, and this is the result. No, just see, this is what is, I am going, exactly in a reverse manner. This is the IVUS picture. What do you think?
So fluoroscopically, the sensitivity of detecting a calcium is very limited to the extent of...
So it means that there is very high chance of
Imaging
it
has
harboring very heavy
Imaging
calcium.
has the sensitivity of say 95%. Here the imaging could very well demonstrate 360-degree arc of calcification across the mid-RCA, which of course was not so evident in the fluoroscopy. Our severity criteria of more than 5 millimeter and so other parameter, but then fluoroscopically we frequently do miss the
So what do you
calcification.
think?
So this seems to be a concentric calcification.
Okay, this is the history. Patient had acute inferior wall MI. And moderate LV dysfunction, and now I am throwing the IVUS and OCT image of the same area together.
And it's
Dense fibrosis may mimic calcium on IVUS. I want opinion of the panelist. Abhiram, Professor Akasaka.
Yeah, there are calcium, not circular, but from 1 o'clock to 5 o'clock, and also the 6,
Yeah.
7 to the right. But there are some fibrotic portion in
Yeah,
there.
then here it looks like 360-degree calcium, and here it looks like significant amount of fibrosis and calcium.
Yes.
Yeah. So how do you interpret? Yeah, on IVUS, that, like here, predominantly fibrosis area, if you try and do, shock wave, it's not going to work, and still you feel that shock wave has done a great job if you have only IVUS. Or even rotablation, whatever. Acute MI, so rotablation is, we avoid.
no, both the picture has very well shown the calcification which is significant enough, and it do require certain plaque modification.
Yeah, but the significant amount is fibrosis, and many areas the calcium is beyond the fibrosis part. Am I correct, Professor?
And thickness of calcium is also less.
Yeah.
Yes.
So this is, again, a puzzle, and this is after post dilatation. This area after dilatation, the same images, 1 to 1. Some hematoma here, and this is broken. And this is the stent result. So sometimes, I feel that both the modalities are complementary to each other.
Can we just ask Tejas, Dr. Akasaka, how often do you see this? I mean, this is concerning that IVUS looks so similar to calcification.
Yeah, very thick fibrous plaque sometimes looks
Yes.
like a calcium, right? So, as Dr. Patel said, if we have a combined IVUS and OCT,
then only,
we can clearly identify.
See, after seeing this, and when I was evaluating both the images, I searched through the literature, and at one place in Gary Mint's article, I found this thing. Dense fibrosis at times mimic heavy calcium. This is a case, a 68-year-old male, hypertension, diabetes, myxedema, inferior wall MI before 6 years. I repeat, inferior wall MI before 6 years, class 2 angina on medical treatment, LV dysfunction, mild, and this is the angio image. What do you think?
It is a ring lesion with a severe fibrosis, recanalized.
Recanalize, right? So which wire you will use, Ajay?
I'll prefer run through extra floppy only because
Yes,
there is some central.
yes, I tried with run through extra floppy, I could not negotiate. I tried with run through extra floppy and 1.5 millimeter, 1.25 millimeter Ruri, I could not negotiate the wire. Now, what will you do? And I had no reason not to cross. So what do you think? Professor?
Recanalized vessel might be.
So then it should have gone in. Abhiram and Samir.
Either it's a recanalized or it's a markedly calcified lesion.
But recanalized, then my wire should go, and my wire should go with balloon.
Just distal to the lesion, if you see the RCA do have certain edginess, honeycombing appearance.
What is this? Just
So that's
concentrate on the
something-
lesion
that's
and
something
the
abnormal.
area surrounding.
That's
think
something abnormal distal
it's-
to the lesion.
It's the, vasora which have opened up around the lesion.
Yes, you said it. You said it. This is intraarterial collaterals which intrigued me. And see, this is the appearance after dilatation. I had to go with pilot 50 and a balloon, and then I dilated.
It might be the
Look at
recanalized
this.
thrombus, right? Honeycomb region, right?
This was I personally feel that there are multiple intraarterial collaterals
No.
in this region. I am not sure, but I have seen this for the first time. What do you think?
It is a recanalized, yes, thrombus.
But then why my wire and nothing went in?
No,
That is
not only a short axis view, but also the longitudinal. There are lots of the honeycomb condition, right?
Okay.
So it may, sometimes identify the recanalized portion, right?
But recanalize, I fail to understand why could I not negotiate my wire and even with balloon, I had to go with pilot 50 after some struggle.
No, it's,
Yeah.
Short axis, but also the longitudinally like a honeycomb condition,
Okay.
right? So it might be very difficult.
Okay.
And if there are some branch from the one area, it might be better to use a cutting balloon to make an communication, right? Simple stenting makes branch closing in this condition.
Yeah, but I had difficulty giving the lowest, making the lowest profile balloon to traverse. But yeah, this was again, something. Any comment, Abhiram?
And no, I mean, I think it is surprising. It was so short, that stenosis, that you couldn't cross, Obviously,
Yeah.
there were parallel
And I was
channels.
not tired. This was in the morning time. It was not like 6, 7 o'clock in the evening after doing 20 cases, I am struggling. No, I was very fresh.
No, Dr. Tejas, which wire did you use and for this particular lesion to
I
cross?
tried with run through extra floppy, I failed, run through extra floppy and balloon, and then I tried with pilot. Again, I could partially traverse, but it was getting knuckled there, and I had to use the same balloon and pilot, and I could enter it.
So it's we have published.
And then I had to deep intubate my guide little bit just to push my balloon in. It was difficult.
Professor Patel tried to make a 3D reconstruction.
Okay.
You can identify.
Oh, that I forgot. Now I have that this data available. We'll make a 3D reconstruction. Great. So this is what we saw.
Dr.
And
Tejas,
this is the result.
We had published 10 cases data about this recanalized thrombus in Journal of Cardiovascular Medicine, and we were so comfortable with using the hydrophilic wire, and my choice of wire was choice PT with the balloon support. As there are the multiple channels, sometimes it's difficult to cross across the lesion, and a balloon support or microcatheter support do help in crossing it.
Okay. So this is the result. This is another case where I am throwing the history first. 59-year-old gentleman, diabetes, hypertension, PCI of LED lesion done before 4 years, again presented with anterior wall MI and severe LV dysfunction after 4 years. And this is what is the picture. Dr. Akasaka knows it because I have learnt the diagnosis after seeing one of your case. So I think we throw it open for others. What is this? You can see the stent is just after the origin of LED, and this is the aneurysmal segment. The stented segment looks good. Now, what is this?
It seems it's ulceration over there as presented with the acute MI or maybe aneurysm
This
secondary.
patient presented with anterior wall MI.
So
now I am
either it's
telling
a
you.
ulcerated plaque, and I'm not sure
Ulcerated
about till
plaque.
what extent the stent is in the proximal LAD, but then this
Acha.
seems to be a new lesion at the ostium of the LAD. And with the eccentricity, it seems it's ulcerated plaque which is presented with the acute coronary syndrome.
Might be stent migration, but it is too late to get a migration. But it is a
Stent
definitely-
migration, Ajay, stent is very snugly fit there. Just at the edge of the stent there is aneurysm. We don't know whether it was there before or not. It was done somewhere else. So, Abhiram, any comment?
Do you know anything about stent sizing? Sometimes if stents are undersized or there's...
No, nothing
ma-
was
or
available. Patient
malapposition.
presented to us for the first time, and we are not aware of that data. Samir, you have any idea?
Yeah, I think I've seen the imaging of this, but I think it looks like there is ulcerated or ruptured plaque at the roof of the left main,
Yeah.
caving into the LAD.
This is a dissection.
Yep.
So now, the thing was, we thought that it is very easy. We will give a good shape to the wire, primary, secondary curve and some lordotic curve and enter the LAD and we will finish the procedure. But today, Ankush, you discussed, right, that under expansion or maybe iatrogenic, sort of a little bit of aneurysm because of the drug ligation stent. Now just focus on the catheter lumen, catheter area, and see what you see. We had a very unpleasant surprise to see this. Are you guys able to make out what is going on?
So right about there, it starts becoming aneurysmal, right?
Yeah.
Right there. And then you see right there is that shelf area.
Professor, what do you think?
Yeah. There are, yes, here you can identify some hole, just, yeah.
Some
So-
hole, yes.
So it might be if there are big atheromatous change and long term, if there are thrombus disappear or plaque disappearance, we can identify. such a
So we took it for I-OPUS protocol, and this is the IVUS. I have already shown in this cartoon, my wire went inside the true lumen through the stent struts. And that is what is seen here. This is some aneurysmal area in the LAD. The stent is little bit hanging inside and wire went in like this. So what? So these are two images side by side. You can see this is the catheter, this is the catheter, and there is a cavity there. There is a cavity and stent there. And then we were able to enter in the true lumen. After imaging with both the modalities, we confirmed, we endorsed our viewpoint, and we fixed it. And this is what was it. This is not a perfect cartoon. We are going to work on this. This is the dissection, spontaneous dissection, and here the hematoma is catching up. It's actually life-threatening problem. It would have extended, patient would have suddenly died. Presented with anterior wall MI, we entered, dilated and stented. And here you can see the spontaneous dissection, and this is a rent from which the blood was filling up and creating a hematoma in the left main. And this is how we fixed it, and then a crisscross and kissing balloon and opened up and confirmed with OCT, and this was the final result. And this was the final result. Any comment on this case? Any suggestion or any idea?
Also, the 3D reconstruction might be very helpful,
Okay,
right?
for these also,
Okay.
3D reconstruction,
Yeah.
all right, we will do that.
And Dr. Patel, can you rerun it, please?
Pardon?
Can you rerun both the images?
Okay. This we are rerunning. At least I feel that we have given a good lumen.
At 6 o'clock, what's there, something overcrowding of the stent struts,
Yeah,
and possibly,
yeah, but see, you cannot fix the whole aneurysm, and you should not, because in the process, if you do stent fracture, then you are giving a grave, prognostic problem to the patient. Restenosis or sudden death or whatever. So we accepted that. Patient is doing fine since last 1.5 years. These are the patients we keep a close follow-up, and I am going to do a check angiogram also, maybe next month for this patient. And we will evaluate with even OCT IVUS run. This is another case, a 67-year-old male, hypertension, diabetes, post-CABG, patent lima to LAD, SVG to RCA, occluded SVG, and SVG, patent lima to LAD and SVG to RCA, occluded SVG to OM, presented with class 3 angina. This is simply, looking at this, what comes to your mind?
It's a calcific nodule.
Yes, this is an angiographic, appearance which should make you suspect calcific nodule. It's a chronic problem, post bypass case after so many years, presenting like this. OM graft occluded, this is tight, angina is because of this. We tried rotablator, we made a channel, we tried with IVL, still nodule, and then we stented, and still not a best appearance there, not the best one. And this was the picture. See, this is a genuinely malignant nodule. When my non-compliant balloon ruptured, I could realize that this was a sharp area which was creating rupture for the non-compliant balloon.
There is no solution at that point, right?
It's a malignant condition
Yep.
in this situation. And another case, A 55-year-old male, diabetic, hypertensive, hyperlipidemic, presented with NST elevation MI, raised TROP class 3 angina and fair LV function. This was the case which made me perspire because it was a live demonstration case done in another country with quite a different audience, and Sanjay not standing besides me, who knows every single move, what I want and what am I going to do. Completely new person assisting me. It started like this, and I was told that it's a calcified artery. We want a rotablator demonstration from you. We have OCT IVUS. I asked for lithotripsy. Lithotripsy was not available. And in the live demonstration program, and here I made a blunder which I want to admit, a very interesting blunder. Ultimately the patient outcome was good, so I am happy. Rotablator was done. And then I evaluated with OCT. It was only 30-35 minutes given to me, and all these things are to be shown. Once the rota wire came out, I had to go in again, and I spent a lot of time there. So very little time left. When I saw this OCT image, I thought, excellent, we have done good rotablation and good dissections everywhere all around, good breakage of calcium, let us stent it. And I stented, and I landed up with this thing. And I was taken aback. What has gone wrong? What is this? So what is this?
Any AP caudal view to comment
Now
about?
this is the view in which it shows the best.
I think it's the wire biased channel created by rotablator.
Okay. Abhiram, what do you think?
No idea.
No idea.
This is
hematoma.
This is a dissected segment which is getting perfused from the
It is severely calcified vessel.
Bent over it. Professor Akasaka, what do you think? No idea.
This is calcified
You
vessel.
have to have idea. You know it. Anyways.
It is stent
Anyways,
malposition.
now I thought that let me quickly do an OCT and to see. I am giving you a clue.
It is a
OCT
malposition.
catheter refused to enter.
So you're in a false lumen of some form?
False lumen? How
No,
can
no.
there be a false lumen?
It is not a false lumen. It is a true lumen
Somehow
only.
stent.
Huh?
Did you stent
It is a
through?
malposition, non-expanded stent. The stent is not
But
expanded
why stent is non-expanded when such
because
a
of
great
severe calcification.
for calcification? We have already done lot of demolition of the calcium everywhere.
Dr. Patel, as you commented, your wire came out after rota and then you again.
No. That after first time before rota the wire came out and I had to go on otherwise. And even otherwise, if wire comes out and if I go through the wrong channel, artery will occlude by now. So then I thought that let me use an IVUS catheter because it has a little better muscle. IVUS catheter with difficulty entered in, and this is what it is, calcific nodule. Then what did I do while interpreting the IVUS or OCT? I hurriedly interpreted OCT. I did balloon dilatation. I will show you the result. The result doesn't look all that bad. But then I interpreted the OCT image. First of all, let me show you at the nodule site, despite dilatation, because the nodule was quite on the septal side, I was not very aggressive. I went up to 15 atmosphere because I was worried about the rupture because the other area was, not calcific. It was quite a fibrosis and normal tissue. It was 4.5 instead of 6. Right? It should be 6 in the proximal LAD, at least. I accepted it. Because when retrospectively I analyzed, I missed this nodule at that point of time, hurriedly interpreting the OCT image. Had I interpreted it well at that point of time, spending good 1 or 2 minutes on interpretation, I would have eliminated nodule and stented the distal area because the side area is perfectly all right. It is a healthy segment and there is a nodule and it is an extremely stable area with a 4.5 lumen. I would have been fine. So now I want an opinion from you. The message from my end is how regular you are an operator or an imaging person, spend good time interpreting the image rather than straight away jumping to the conclusion, seeing what you want to see initially. So what is the Samir, you tell something. What should have been done?
I think these are almost impossible to treat anyway because.
So I would have left it. Another important thing, we do imaging because we want an excellent cosmetic result, right?
Right.
By and large. Here, imaging should have helped me eliminating this complication-prone nodule, giving not so good and little bit ugly image on angio, but I would have known that my patient is going to remain very stable. Had I deployed the stent just distal to this nodule. Professor Akasaka, what do you think?
Yeah, I want to have a longitudinal image, but based on the wire position, we can make an ablation if we want, using orbital atherectomy or something. Yeah.
Orbital?
Yeah, if we succeed to ablate this portion, the result might be much better.
But from 1.75 bar, it could not ablate this. So I don't know the thickness of the calcium or what. And here I am sure that lithotripsy might not have worked in this calcium,
yes,
because so many of the pulses would have been wasted in this region.
Yes.
Any comment, Abhiram? So this was a blunder, and the message is spend good time interpreting the image before straight away jumping on the conclusion. Another case is a 40-year-old male, hypertension, presented with NST ACS, post PCI LAD 18 month. Now the patient is a drug defaulter since 2 months and presented with moderate LV dysfunction, and this was the angio picture, anterior wall MI, drug defaulter, stented before 18 months. Now, like supposing you have no access to imaging, what will you do? Simple, you will make sure that this area is stented.
Right.
Agreed or not?
Yep. Makes sense.
Now we are doing imaging. This is all white thrombus, and in the disturbed area and the area which looks great, just concentrate on the OCT image of this great area and see what you see here inside. Look at this, look at this, look at this. This is the area which looks perfect on angio in the proximal part. And this area, these are the few slides on this area. So what is this? Again, the thrombus hanging here and there in that segment. So what to do now? What to do? We decided to stent the whole segment again, because there was neointimal proliferation, and on the top of it there was some good amount of thrombus hanging on it. And we ended up with this result, and now see the OCT.
That's your MSA right there, right?
Huh?
Yep.
So now that ugly looking area, in that area we are moving. It doesn't look all that bad in this region now. And with a good MSA. Huh? So any comment on this? So this is the place, these are the cases where you come out with some very interesting observations with imaging, which can really modify your plan about final strategy.
Was it a undersized stent in the proximal LED nidus for the thrombus formation?
See, we were all the time focusing on the problem, so I don't know that part.
See this horizontal plane of the OCT,
Not really.
Proximal
No, not
end
really.
of the stent.
Not really.
Maybe
Not
a
really.
measurement over here can give an idea of how much is the MSA compared to distal or the mid part of the stent. So that's a predisposing factor to have a thrombus formation.
Professor Akasaka, any comment on this?
The thrombus is just distal to the stented side, right?
Yeah.
Yeah,
And
here
the
we
from-
can identify the red thrombus, but there are no stent strut. And then we can identify the thrombus start from at the edge of the stent strut.
But the inside the clean area also you see what? what you
Yes,
see.
yes,
Yeah.
there are some thrombs, yes. Yes.
And they really look bad in certain regions. So this was the problem, yeah. A 49-year-old male, diabetic, hypertensive, NST, ACS, good LV function, 90% lesion in ostial left main. I was showing a fibrous lesion and a very tight stenosis, a very small MLA. Plan was to perform PCI or left main under IVAS guidance. This was the picture, and at the end we evaluated with IVAS, we stented keeping 2 wires, and this was the result. Result looks perfect. So what is the normal instinct? Here we evaluated using OCT. It looked good. It looked good. But still we have a tendency to do something. Anybody have any objection for this left main ostial stent result? It looks fine to me.
Distal edge, there is some.
Distal edge, Ajay, was fine. There was no problem. At the ostium, just tell me. Now, epicranial was also good. Here they have not put, but yeah, I can tell you that. But any time we are doing left main ostium with IVAS, after stenting, we pull our guide catheter back in aorta a little bit, keep it hanging, and then we interpret the IVAS. And this was what it was. We injured the stent strut at the origin, and the circular lumen was completely oblong in that region with 8.19 MSA. And we corrected it. After correction, it became 11.41. Keeping the lumen just like that, if restenosis or some other blocks develop, whosoever is the operator will perspire to have coaxiality, cannulation, and if further injury to the stent beyond the left main is done, then patient has a permanent problem. So every time you evaluate, particularly in the left main, all young guys who have started doing it, you make sure that after stenting, pull the guide catheter little bit outside the left main, hanging in aorta, and do your IVAS run to avoid this type of complication. It was a very simple case, but I think it had some good message, so I have kept it. Just you can see the difference. Now this is, I think this case has already been published in Jack case report in the first, like Samir?
Yeah.
She's a 25-year-old female presented with ACS, inferior wall STT changes, raised troponin, giant aneurysm in proximal right. Because it was giant aneurysm, we did a good workup of this case by doing MR angiogram of brain and abdominal vessels to rule out aneurysmal site in the other vasculature. Everything was unremarkable, and the plan was to seal the aneurysm using the covered stents. But this was the picture, scary. Patient was advised surgery in 3 different centers in different states in the north and India and western India. Patient came to us with some hope that if we can fix it internationally. She was a marriageable age and she came with the fiance. That was a very emotional story. A young girl who is already a working woman. And it is almost like an impending rupture type of aneurysm. So we always keep a good number of covered stents, although they are not available nowadays, but we procure. So we have papyrus as well as graft master. Unfortunately, we thought that 26 millimeter papyrus should be fine in this case to fix it. But unfortunately, when we measured the length by putting the wire, the length was coming at around nearly 30 millimeter. So, what to do? You deploy one stent and then you put another stent, and if that covered stent doesn't go inside the previous one, then you are stuck and the whole area is, very sort of a loose area. Here, my colleague Sanjay came out with a brilliant idea. Brilliant. He told that let us prepare a platform using a longer stent, metal stent, and then we can use overlapping covered stent to fix it. And we used the 3x38 Zion's expedition, prepared a platform, and 2 overlapping covered stents, papyrus were deployed. This was the stent deployed, Zion's. And then after establishing the platform, 2 overlapping covered stents, 3x20 and 3x15 millimeter, keeping about 2 or 3 millimeter overlap, were fixed one by one. And this was the picture. We were able to exclude the aneurysm. Okay, we did OCT. This is a normal stented segment, and there it's a full moon eclipse type of picture, and this is all red thrombus all around. Red thrombus, and then again the normal area where the stent was extended. Now, this was the difference. Now, 9-month follow-up angiogram. We insisted the patient that we want to do our angio between 6 and 12 months. 9-month follow-up angiogram looking great. 9 months, the same time we did OCT. This is a normal, and now you can see the red thrombus probably got converted into the sort of white thrombus, but because of the cover and other things, but it looks little different as compared to the previous one. And then there is some sort of overlap of the stent which shows some proliferation, extremely acceptable type of proliferation. And so now it is almost 2.5 years follow-up. Patient is doing fine. But yeah, this was a very gratifying intervention, where we were able to, exclude the aneurysm and getting encouraged with this. This was the other case, but here the first injection and patient developed ventricular fibrillation. You can see that. And a big aneurysm hanging in the obtuse marginal, again impending rupture type. VF was reverted using shock, and after sinus rhythm was established, we evaluated the area. Here another problem is the patient has a pretty big circumflex. If I cannot exclude that circumflex, it would have become very easy for me. This is the history. NST, recurrent angina, ectatic arteries, aneurysm, and impending rupture, normal LV function. We made sure that we don't exclude the circumflex and deploy the papyrus just beyond the origin of obtuse marginal. But in that case, there was a little bit of rent which was left there, and you can see some oozing going on in the aneurysm at that point of time. We took the patient again on table. This was in another view. You can see. Next day we evaluated with OCT, and you can see this is the excluded part, and here there was a rent, the area which was open through which the blood was pouring in, and we are awaiting the check angiogram of this patient, maybe in 2 or 3 months' time. So this was what I wanted to show. Now I want to keep the session open for any further discussion or any question or any query you guys have.
So, Tejas, have you had more experience with those covered papyrus stents for this use? Because obviously with the geomets we used to worry about patency rates and so
Pardon?
on. The patency of these covered stents,
So that is the reason, Abhiram, one patient was very young, the other is a middle-aged but still a young patient. So this was our first experience, and frankly speaking, a 25-year-old girl, to open the chest for right coronary artery did not, enter my head. And here, for obtuse marginal, you advise surgery or you exclude the circumflex, which can lead to mitral regurg, acute MR in this case. That was also not entering my head. So that is the reason why I took. And restenosis is a treatable condition. Anyways, the patient will remain stable. That is what I felt. And with availability of good antiplatelet regime, normally our protocol is for first 4 months we give Brilinta and aspirin and then aspirin clopidogrel combination. These are the patients who are kept on Brilinta and aspirin for 1 good year.
do you plan to bring that young woman back for CT or some kind of imaging of that coronary
Pardon?
artery? Will you image the coronary again?
Yeah, first case we have evaluated after 9 months, other case between 6 and 12 months, patient should be coming in a couple of months time, and I will try to convince them, okay, now at least we should have your CT angiogram, but CT angiogram I am not sure how good or how bad it will look with all these things inside the coronary.
I think OCT might be the best, right? If you
I
do
think
a-
so. I think intraluminal
1 year
OCT can
OCT.
be the best thing. So I will try to convince them, and we can do completely free OCT. There is no problem in this type of case. So any query, question, anything, the session will be thrown open for some time.
Dr. Akasaka, coronary aneurysm secondary to Kawasaki disease, like in the first case versus atherosclerotic disease in the second case. How do you differentiate with the imaging? Is there any difference between the two?
It's a very important question, I think. Yes, the Kawasaki disease, sometimes pediatric cardiologists already diagnose the presence of aneurysm. And when we try to identify the aneurysm by the Kawasaki disease, we can identify lots of calcium around the aneurysm, and also sometimes entry and the exit, sometimes some stenosis. Therefore, the lady, a very young lady's aneurysm is completely different. It's yes. we can differentiate the presence of calcium.
The first case, Rajesh, we suspected Kawasaki or Kawasaki-like syndrome, and that's why I was chasing for any other aneurysm in the vasculature.
We had a publication in Journal of Rheumatology regarding Kawasaki disease presented as the coronary aneurysm in adulthood. And then we have come across few young patients where we have put the stent across and then had a long-term follow-up as well.
So, Samir, if you have certain queries or something which at least we can ask Professor Akasaka or we can discuss here.
Yes. So I think, in a scenario where, how can you predict wire biasing with rotablator? Let's say you are doing the ostium at the diagonal.
Yes. Yeah. Always when we get an image, try to check the wire position. I'm not sure that completely the same when we do the rotablator or orbital atherectomy, but it is very useful to identify the wire position by imaging. And we can control using the wire pull back or push in a little bit, or using a much hard wire, right? So, for example, if we treat the LAD and the calcium is the myocardial site, during pullback by orbiter is very useful because orbiter always move as a skipping loop, right? So therefore, if try to use the orbiter during push in, a loop goes to the epicardial site. Right. At that time, we may have the risk of making aneurysm. Therefore, during pullback, so wire pullback or push in is very important to make a much better wire bias. Right.
And to add further, Dr. Akasaka, what's your experience regarding the rotabary speed 120 versus 180 and 200? Is the decreasing in the speed is going to help to have an eccentric calcified lesion ablation?
Yes, that's right. So, it's depend on the operator. But sometimes try to change the speed of the rotablator. Yes, it is very useful, right?
If you cannot advance the imaging catheter, would you automatically go to some ablation strategy?
It may have some risk, but if any kind of device cannot pass the stenotic portion, anyway, we try to do the ablation using a rotablator, using a small bar. But the 1.25 sometimes may have the risk of stuck. Therefore, we often choose 1.5. Right. It might be better, but it depends on the size of the vessel, right?
And is it better than using small balloon and dilating it and expanding it just to deliver the imaging catheter?
Yes. If we can dilate using a small size of balloon, it might be better to use an imaging first before the ablation. But any kind of device cannot pass.
Then ablate.
It might be very difficult to get an image, right?
Thank you.
Anything?
Any other questions, any of the audience?
Another case, you had a left main, there was an aneurysmal segment, and you had put nesting. How do you exclude that aneurysmal segment with the non-covered stents?
We met at times, Dr. Paul, we may not be able to exclude the aneurysmal segment, but like if it was a 4 millimeter stent, I don't mind making it 4.5, but I will not use a 6 millimeter balloon to exclude it, because those, I tell you, those are the places where the short segment aneurysm and properly proximal and distal apposition done, those ultimately the pressure is low in that region and ultimately the wall collapses and the things look much better later on. This is what is my personal experience on good number of cases, and I want to know from other senior operators what do they feel about it. Yeah, it was a very valid question from your end, what to do, because we feel again the question of aggressively doing apposition, does it matter every time or not, right?
Yep.
See, sometimes the aneurysmal segment is too much dilated, and putting a balloon across, you are going to have a stent deformation, stent fracture, and the result is not going to be good in the long term. So a hanging struts across the aneurysmal segment with a good apposition proximally and distally can have a good result. But then I'm sure about instead of having a spontaneous collapse, this is the nidus for thrombus formation. So continuation of dual antiplatelet therapy for a long time is, that's what is required.
For 1 year, yes, and then I think the things settle, because many times, like we see so many arteries with endothelial dysfunction where tight stenosis, relatively normal segment, little bit aneurysm, again tight stenosis. When we cover everything, that little bit of aneurysm, we dilate, but we don't dilate to the extent that we break the stent struts.
Right. Yeah, I think, as long as your proximal and distal is a great result, the ectatic area, eventually thrombosis, and when we bring them back a few years later for a different reason,
it's fine.
It's always a smooth
fine.
lumen there. Always a smooth lumen.
Yeah.
I've seen anecdotal case reports of coil embolization behind the stent. So the stent is put in place, you put microcatheter, embolize the aneurysm, and then stent it.
Yeah,
And there have been reports of that.
These
are rare.
I think that is
But I
too
wouldn't
much
do
of
that in the left
stretching the
main.
limit.
Yeah, that would be in the
Actually-
left main, but in other locations.
Actually, the last case, we can do that. If the aneurysm is persistent after putting that PK papyrus in that OM, if there is a small opening, we can put a coil and we can occlude it.
Right.
We had one case, Dr. Patel, where the LAD D1 aneurysmal site was there, where we did put the normal drug-eluting stent, and they had no coil embolization on the aneurysmal. We had no follow-up by now 4 to 5 years, and patient is doing well.
You did the coil first or the stent first?
Stent first to be followed by coil.
I personally feel that I will leave it alone, because there is too much of metal getting accumulated in that region, which is a very sort of a dicey region. Huh? Covered stent, it was inevitable in these two cases. Oh,
No, it is not possible.
No,
It is
coil
not
will not
possible.
remain there. He says that you put a stent and then through the stent you put the coil, right? That is, no, not a great idea. Yeah. But
Again, putting a ramp master in a osteoporosis already was not a great idea. That too, having a large diameter.
Yeah.
And he was not willing for surgery.
Yeah.
That was the only solution that was available for that patient.
Normally you are changing the pressure dynamics in the aneurysmal segment by putting a regular stent. The pressure will be low. There will not be any other injurious, forces which can influence that region, and ultimately it should collapse. I am not saying that it always collapses, but this is what is the hypothesis on the basis of which we practice this, and we are not disappointed most of the time.
Hello, I just wanted to ask two questions. One is, what is all the masters are over here. What is the individual strategy of modifying a calcific nodule, number one? And number two, sir was talking about acetylcholine provocation test. Is acetylcholine available in India, and how to go about it actually, acetylcholine provocation test?
I don't know about it, acetylcholine, whether it is available in India or not. Ajay, you have any idea?
No, I also don't.
Rajesh? So, yeah. So,
It's not a cardiac preparation, it's an ophthalmic preparation that has to be made for intracoronary infusion, but it's certainly available all over the world. So it's just a case of getting it. Japan uses it, Europe uses it, and US. So I can't see a reason why you couldn't. But recently we had for the first time ever, there was no supply of it. So it's not made by one manufacturer.
yeah. So I think it is a long day. We can conclude here and catch up for the dinner, maybe 8:30, and let us have a relaxed evening. Tomorrow morning, I request everybody to come on time, because all the speakers, they have done a lot of hard work to prepare their talks, and I think we should be listening to them. And tomorrow we will keep a couple of cases which may not be as complicated like this, but we will carry out good discussion. And tomorrow I think we will be focusing significantly even on the physiology part, because that is what the understanding of what is quite lacking in this country. And there are problems, as far as Indian arteries are concerned. That is what I strongly feel working with physiology things. So thank you very much for being here, persistently getting glued to the chairs all the time, and that keeps all of us very happy. And I hope this master class contributes in the learning of everybody. It has contributed significantly in my learning, and I am thankful to all my international guests and national guests and all the participants. Tomorrow we will meet and we will make a half day very interesting. Thank you very much.
Thank you.